So let me also extend my welcome to all of you. It's going to be a very exciting morning packed with quite innovative ideas and progress that's been made on those ideas. The first one addresses one of the most vexing, if not the most vexing problems in our hospital and in many hospitals, which is capacity management. How do you move patients through the system in a more efficient and quality-oriented way? And the speaker to begin the morning is Dr. Peter Dunn. Peter is the vice president at the hospital in charge of perioperative services and healthcare system engineering. And Peter and his group with MIT have done very innovative work that you'll hear about, modeling using AI to predict which surgical patients are ready for discharge. So, Peter?
Thank you, Dr. Lewis, and good morning, everybody. It's my honor to be here representing a body of work on behalf of our entire team. The status quo of discharge practices leads to suboptimal patient care and detrimental effects on the patient experience. Mass General, like most other institutions these days, is running at near maximal occupancy each and every day. As you can see on the graph on the left-hand side, as we function at these very high levels of capacity, our patients endure pretty significant wait times, and those wait times get worse as the capacity increases. The real problem is a lack of timely discharges to create the supply of beds for those patients who need it, as seen on the right-hand side of the graph. The red line depicts the request for the beds, and you can see that that red line is out of phase with the orange line, which is actually the discharge time for the patients who are currently in those beds. And that leads to a delay of the patients needing a bed and getting into the bed, which is reflected by the blue line on that graph. These delays lead to overcrowding in the emergency department, which is a well-reported safety patient risk. It leads to delays in the intra-hospital transfers. Our team has published data that when a patient is delayed leaving an ICU after they no longer need to be in that ICU, they don't make up that time when they reach the floor. Their total length of stay goes up. There's an inability for us to find beds for patients at the outside hospitals that need to come into Mass General and other tertiary care centers, and that's an access problem. And finally, we have upstream delays due to this inefficiency on our floors, which has negative impact on areas such as the operating room, where we have significant delays of getting patients into the OR. And this could have a revenue impact if those patients tire of waiting to get their scheduled surgery and seek their care elsewhere. So status quo is not sustainable. So what we have done is we have created a discharge prediction model, and what we've done is to make the discharge process more transparent, data-driven, and automated, we created this tool. What we did was we extracted more than 900 variables and data out of the electronic health record, both clinical as well as administrative data points. Points such as the vital signs in the record, moment by moment, patient information in the nursing flow charts, lab data, radiology data, as well as key administrative data points such as the patient demographics, where they are in the hospital, and other important components of the record, mainly by free text, such as the case management notes. We used a proprietary clinical framework, and you can see here in the middle one of those frameworks, or a portion of one for a surgical patient, a general surgical patient. And then we used that information and trained a two-layer 20-nodal neural network to create a highly reliable discharge prediction tool. The output of that tool each and every day is a rank order of all the patients in the hospital by their likelihood to be discharged within the next 24 hours. It gives us a total number of patients who will leave the institution, not only across the entire hospital, but floor by floor. And most importantly for our clinicians, it provides a comprehensive list of what are the discharge barriers that those teams are trying to overcome independently to get their patients discharged from the hospital. The tool can be used daily by multiple different clinical and administrative teams. It can be used throughout the day by the physicians, the nurses, the rounding teams, as well as the bed management teams in the administration. There are several different ways we can use the tool. We can actually look at what were the mismatches. Those patients we predicted would leave yesterday but didn't leave. When they don't leave on the day predicted, we know they have a high likelihood of leaving today. We can now prioritize those patients as the one most likely to get out of the hospital earlier in the day. We can view today's discharges, and that's seen in the middle where you can see a list of 146 patients on our surgical floors. 37 are predicted to leave, and when we look at the next day, 37 indeed left. And as I mentioned for our clinical teams, there's a list of barriers to discharge, and that's shown in the far right-hand part of the screen. Thus, what we end up with is a common list that is transparent and known to everybody throughout the institution, and then everybody's accountable to help with this cumbersome process known as the discharge of the patient. This assists the busy clinicians and helps unload the administrative burden, a theme that we've heard about frequently over the last 2 days. What's the market for this? In conversations with others and primarily our colleagues throughout the United States who are faced with these same challenges, it's a large market. And if you look at worldwide, all the other hospitals in the other parts of the world are facing these same challenges. So there's a worldwide market as well. At Mass General, we completed a 90-day pilot on a subset of our surgical floors. And on that set of floors, it's about 7% of the total number. In 90 days, we had 128 saved bed days by enhancing and improving the discharge process. Just on those floors alone, that annualizes up to 3,000 beds. There's a market for these tools for any hospital, which is pretty much all the hospitals who are facing both access issues for their patients, but as well as margin pressures. The customers are anybody who has an electronic health record, and the current reports are that more than 90% of the acute care hospitals have such records because we're data-driven to create this model. And with an aging population and a reported shrinking of the numbers of acute inpatient beds, it's going to be even more important for us to better manage those beds, both for the margin pressures, but more importantly, for the access to care issues our patients face. This proprietary tool has been developed and proven at Mass General Hospital. The tool can actually be used to improve asset utilization, operational efficiency, as well as financial improvement. As I mentioned, it was developed at Mass General, and we've had a team, as David mentioned, in a collaboration with MIT, where we've got more than a decade of experience of applying operations research methodologies and AI to face the largest challenges in our hospital, and this is just one aspect of that body of work. We are continuing to expand the use of the tool at Mass General. After the pilot phase on those few surgical floors, we are now expanding out to all the other surgical floors. Given the fact that the pathway for medicine patients, oncology, cardiology, psychiatry are different than they are for surgery, we've had to refine the model a bit. We just finished validating that, and we will be soon piloting the use of that tool on those other services. And once those pilots are complete, we will actually be using it throughout Mass General. And the goal is to expand that also to the other partners institutions. So what we're looking for is a partner to co-develop a user interface and a mobile app. And we realize that if this is really going to become a useful tool for our clinicians, it needs to be in their hands at the time that they're taking care of their patients and doing their rounding. We're also looking for a commercialization partnership with a company to both market this tool, either as a standalone software or incorporated as a component of a operations consulting service as one of their tools. So I want to thank in closing Chris Coburn and the IDG program for their generous support of our team. We'll be outside and happy to carry on the conversation with anybody that's interested or answer any other questions. So thank you.